Good afternoon. Welcome to the e-ESRA Residents and Trainee session. My name is Maria TILELI. I am the former trainee representative. We have a session today for trainees and not only. We have two speakers joining us and one live demonstration. We will first begin with the discussion topic of simulation training by Dr. LLOYD, who is a consultant at Newport, UK. And he's going to join us soon. He's here. And we will take up the questions following the presentation, and then we will move on to the next session. So over to you, Dr. LLOYD.
Thank you for that, Maria. So the first thing I wanted just to clear up, which you've mentioned, I'm down on the programme as being in the USA. And although the UK feels like it's moving slightly further west every day, we haven't got there yet. I'm still here in the UK. So I'm going to talk a little bit about the role of simulation in regional anaesthesia. So if I jump straight into that, I got interested, or more interested, I suppose I should say, in simulation when our Royal College changed our curriculum back in 2020, which was a feat of fantastic timing. And it's that same competency-based curriculum that many other places around the world now follow. So our trainees need to demonstrate competence in various different techniques of regional anaesthesia. And the difference is that they now need to demonstrate much more competence much earlier on in their training. And that for us as trainers means that we need to be able to provide them with more learning opportunities. But actually in the post-COVID context of reduced clinical activity, that's proven quite a challenge. So what we wanted to do was somehow figure out how we could provide that learning opportunity, ideally in an abbreviated package and ideally centralised, because we have trainees all around Wales and they all have a slightly different experience and slightly different learning opportunities. It'd be nice to centralise some of that. So for us as teachers, it seemed to make sense that simulation was going to be the answer for these problems. But as ever, when you want to persuade some money out of somebody higher up, you really need to provide some evidence to justify that. So looking through the evidence, this is the sort of summary of where we are at the moment with simulation. So I think the first thing to understand whenever you're teaching anything is what the learners need to learn. So if we look back at the ESRA guidance from back in 2009, these are the key skills of learning a regional anaesthetic technique: understanding the device, getting the best image, interpreting that image, and then introducing the needle in a safe manner. And on top of those, if you want to then turn that into effective clinical practice, we want to be able to talk to the patient about informed consent. We need to be able to manage their and our behaviour throughout the surgery and throughout the block. And if you're somebody who's performing regional anaesthesia, you've got a duty of care for that patient. You need to be able to make safe, sensible decisions around any complications that happen. So there, altogether, is what somebody needs to learn if they're coming from nowhere to manage safely a regional anaesthetic technique. So what simulation's available? Well, we can split that into part task and high fidelity simulation. So part task trainers are the ones that a lot of us are familiar with, and they're really good for learning procedural skills. The most common ones we use are phantoms, and they can be the simple blue gel inorganic phantoms. So they have the advantages that they're reusable. They're very good for learning needle probe coordination. You can visualize that on screen. But when you're needling them, they feel nothing like tissue. They're quite unrealistic in terms of the feedback they offer and have a poor representation of the anatomy. And compared to the organic ones, they give you much better, more realistic sort of anatomy because they've got real tissue. They've got real tissue planes that you can pop your needle through. It feels very much more like clinical practice. But particularly here in the UK, we have a lot of governance issues around them. So any tissue that we use for medical purposes, you have to buy through a medical tissue supplier. You have to dispose of it in the same way as you would with any other tissue. And it doesn't last very long, so it's perishable. And there's ethical issues around it, which some people aren't very keen on using animals for that. The best phantoms really are cadavers, particularly the soft embalmed ones, the sort of teal type cadavers. But we have to recognise they're a really privileged resource. Certainly we don't have access to any in Wales. I'm not going to be able to make the case to our governing body to get us that much funding to get us those. And probably the best and most high fidelity method of learning scanning is to use human models. They're very high fidelity for learning a variety of anatomy. So you can learn how to scan people, you can learn how to interpret their anatomy, but understandably, people are not very keen on being needled and injected, so it doesn't teach you that whole skill. And what I'm going to talk a bit more about today is these newer modalities of virtual reality and augmented reality. And these often get confused. So virtual reality is where you generate an entirely virtual environment which somebody can go into and interact with. So think about putting on some goggles and then having an entirely false environment which is set up in a clinical scenario which you can interact with. Versus augmented reality, which is where you have an element of simulated modality or simulated image of some sort, but then that's brought into a real environment. So that can be something, for example, like having a superimposed ultrasound image over a human model, which has been done for neuraxial anesthesia, or that can be done for introducing something like a sham needle onto a real ultrasound image. So there's a real element in the ultrasound image that's live. There is an augmented reality element from a false needle. And then high fidelity simulators, which I mentioned a moment ago, they're very good for practicing a whole clinical scenario. So they're good at teaching you those non-technical skills. They're good at working on teamwork and working on safe practice, particularly for managing rare situations that you can't guarantee all trainees are going to be exposed to. So things like LAST is the most common thing that we think of for regional anaesthesia. So does the evidence support us using simulation? Well, in short, yes. All the modalities that have been examined, simulation seems to show a benefit for. So whether that's increased written test scores, whether that's improved sonoanatomy knowledge, it has been demonstrated to shorten that learning curve for people gaining competence in regional anaesthesia. And probably most compellingly is that people who've practiced on a trainer and had simulation teaching, their initial first series of blocks seem to be more effective than those people who have not had simulation training. But one important caveat to all this is to say that the how you use your trainer is much more important than which trainer that you use. So there's been several papers on using various different regional anaesthesia training devices and simulators that have shown that actually the gain you get is equivalent between them. And there's lots of research to suggest that if you just let somebody explore and learn on their own using a trainer, they're not going to get the most benefit from it. The most benefit from using any form of simulation comes if you engage those principles of deliberate practice. So that is having contemporaneous, structured feedback from an expert. And that's how you get somebody to change their behaviour and learn that skill much quicker and more effectively. So some critique of the science of simulation at the moment is that the study numbers for most of it are small. And it tends to be that if somebody gets hold of a simulator and they're going to produce some data on that they normally set up a whole teaching intervention. So they might do things like some online learning, some face-to-face teaching and some simulation, and they investigate the effect of the whole package. So actually piecing out the simulation component can be quite difficult, but certainly we know that those packages as a whole are very effective. And the outcomes we tend to measure can be quite different. Some people measure speed of needle to target. Some people measure the amount of time you have your tip in view. Some people measure more global indicators of success like global rating scales or quality compromising behaviours. So they're all good measures, but they're different between the studies, so that can be quite difficult to compare. And most of them tend to focus on learning the skill, which is our focus for teaching, but it's not immediately clear what effect that has in a clinical environment, whether it changes what people are doing at work, and most importantly, whether it changes what the outcomes for the patients are. So we're still at that relatively low level of that pyramid of learning. So when I came to try and devise some simulation teaching for our trainees, I came back to looking at those e-ESRA recommendations again and thinking, what's the most effective way of achieving each of those goals within that learning? And I think these ones are highlighted here in green. They're easiest and probably most effective to teach on a human model. So you can get somebody to optimize an ultrasound image using any clinical ultrasound device without needing any additional fancy simulation equipment, simply using a volunteer. And if you have volunteers, you have an almost infinite variety of anatomy which people can learn, and they can learn how to interpret those images. What's then more challenging is to teach people needle probe alignment and to get them to introduce a needle safely. And you can do that in isolation on one of those blue phantoms, but you can't do the first bit. Or you can do it using one of these part task trainers. But one of the pitfalls of using these part task trainers, and I've taken this from a research paper that's been published of an excellent looking simulation package, but this image highlighted me one of the pitfalls of using a part task trainer is that because you're not using a real person, you're not using the same ergonomics. Now, no one's going to do an interscaling block in that position, and unless you're quite conscious of manipulating the environment, the part task trainer can lead you into practicing something that you're not going to do in the real world, so the fidelity of it drops a little bit. So what we wanted to do was to be able to teach people the whole package on a real person. So we could scan them, we could get them to interpret the image, and then we could get them to introduce a needle somehow into that image so that they could put the whole thing together in a slightly higher fidelity way. And what we settled on is this device called the needle trainer. It comes as two different bits. The first part helps people to learn the anatomy that they see on the screen. So it uses AI to highlight things like muscles and nerves and arteries, and then that allows people to improve their recognition, and they can progress towards turning that off and interpreting the image on their own. And then the bit that we use much more of is this sham needle device. So you can insert this sprung probe onto someone in a way that you would like a normal needle, and then it produces this sham needle on the screen, and we can give them a target to aim at, or better still, they can choose a target to aim at. They can introduce their needle to it, and we can give them feedback in real time as to what they're seeing and how they might be able to improve what they're doing. And the biggest thing that we liked about it was that you've got this infinite variety of anatomy, and the fact that you're using a real patient means that you gain a lot of those extra fidelity elements around performing a whole procedure. So you've got to look after your patient because they're a real patient and they need to be comfortable. You've got to manage the environment that they're in. You can set it up so that you've got a skilled assistant, that you're using simulated equipment. You can do all of those behaviours that you'd expect a trainee to produce in a real working environment, and get them to focus and improve on those. So when we started developing our simulation programme, which is now running across Wales, what we started by doing was giving people pre-course readings. This is something you can do in their own time at home, because not everything around regional anaesthesia needs to be simulated. So we've got things like these Plan A block posters, which we developed for ESRA about 18 months ago. We get people to do the pharmacology and physics reading beforehand, and we do an online exam to make sure that they've retained and are able to use that information. Then we start with this lowest level of simulation on a live model. So they scan the anatomy, we teach them how to improve the image using the ultrasound scanner, and they learn to recognise basic anatomy of the abdominal wall, basic anatomy of the brachial plexus. And then once they progress through that, we then do a whole task of simulation. So we do a couple of peripherals and superinguinal fascioiliaca, and we do that with that needle trainer device. And we then focus on those behaviours around keeping your needle probe aligned, about how to re-find your lost needle, those types of activities. And as I mentioned before, we're very conscious of this idea that it needs to be deliberate practice. So we have expert faculty there, and they are constantly giving feedback and making people improve what they're doing. And I think anybody that is thinking about setting up their own course really needs to take that bit on board. It's the feedback that's really important, far more than it is about what piece of software or what piece of simulation equipment they're using. And then the last thing is, how do we quantify whether this is working or not? So we get some feedback off the trainees at the end of each course, but we also try and offer them structured feedback. So we use the AR software to give them some metrics, so the needle tip in view, to see how often or how much of the time they're seeing their needle tip, which is obviously an important safe behaviour. And then we use some objective scoring methods. So we've used global rating scales and checklists, which are validated as a way of assessing whether people are doing something safely and effectively. So, excuse me. And gratifyingly, this fits with what Ed Mariano has produced in one of his latest papers. So our course fits neatly into what he would describe as this basic resident trainee package, where we talk about optimizing the patient, we talk about what regional anaesthetic techniques are appropriate and how you'd manage those. And we have a different set of simulation-based teaching where our trainees do high fidelity sort of lab-based simulation, and one of their simulation scenarios is local anaesthetic systemic toxicity. So thankfully we can offload that responsibility onto a different course, and we just focus on the procedural skills part. Very important to note that that is done as well. So my inflammatory closing statement for you is this. So we know that regional anaesthesia causes harm by operator error. It can cause harm in other ways, but that is one way. Early stage learners are definitely more likely to exhibit those behaviours, which can result in harm. And all of our available evidence suggests that simulation can reduce the rates of those behaviours. So I think, and this is the case that I made to the people that foot the bill for our simulation teaching, is that in 2023, it's unethical for our anaesthetic trainees to begin performing ultrasound-guided regional anaesthesia without first having practiced on a simulator. That's my take on it. I'm willing to hear any questions or alternatives from anybody else. Thank you.
Thank you very much. That covered a lot of points in training, regional anesthesia training. Of course, a lot of trainees are having different experiences on how they gain the experience in regional anesthesia. I wanted to ask you, Dr. Lloyd, in your simulation program you described to us, roughly how long does it take for a trainee to actually begin do their first block on a patient, considering they've done all the simulation steps?
Well, the idea that we wanted to get with this simulation is that we there as trainees, go to a list, and your first step is to say, okay, you're with a new consultant and you watch the first block, and then they're unsure about what level of skill that you've got as a novice trainee. So the idea with this course is that it would get people from never having done this to a level where it's appropriate for somebody to be supervising them, directly supervising them, to perform something on a real patient. So this course takes about 6 hours, something like that, and they get to do an awful lot of practice in that. And then the idea is that then in their next clinical opportunity, that could be days to weeks later, they're then at a level where it's appropriate for them to have that guided, directly supervised experience on a real patient. So essentially what we're doing is we're introducing that simulation step before, whereas what would have happened previously is they'd have just gone out and tried this after watching somebody in the same way that we learn an awful lot of medicine.
Mm-hmm. Fantastic. Well, thank you very much. It was very insightful and a lot of things to discuss, obviously, in terms of training. We will move on to our next speaker. We have it's Professor Ed Mariano from Stanford University. Unfortunately, he is not here with us, but he has recorded the session on social media, and if we can learn from social media, regional anesthesia and pain medicine. So we're going to move on to that now.
Well, it's a pleasure to be part of the e-ESRA webinar. I'll be discussing this topic: can we rely on social media to learn regional anesthesia and pain management? My name is Ed Mariano, and I'm a professor at Stanford University in California. I have no disclosures. And the first thing I should probably say is that there are various ways to learn regional anesthesia. I think that oftentimes we tend to think about our training as anesthesia residents and fellows, and then progressing on to being a practicing anesthetist. However, I think this is more of a traditional route, and I think that the way that we train our residents in regional anesthesia has definitely evolved. And then the fellowship programs, at least in North America, really only date back until the 1980s, and it's only since in 2016 that we've actually had the opportunity to do fellowships that are nationally accredited, at least in the United States. However, the majority of our anesthesia colleagues who actually learn regional anesthesia will learn it out of training. And the reason I say that is because for many of us who practice medicine, our careers are about 30 years long or sometimes longer. And so for those who trained in anesthesia before some of the popular techniques using ultrasound were developed, many of whom include myself, we've had to learn regional anesthesia on our own. And so there has to be this track for the practicing anesthetist to learn regional anesthesia and then also keep up with the latest and greatest in new techniques and innovations. And so when I think about the literature, especially as it's evolved over time, we've seen really an explosion in fascial plane blocks. And we see this through publications, although we know that publications really underestimate clinical practice. If we do a PubMed search of plane block as the title phrase, we actually see a yield of about 400 or more articles per year for the last 4 years. And that's fairly, I would consider that a very, very large volume of new literature that has really changed the way that we practice regional anesthesia in clinical practice today. So when I think about social media, I think social media really represents a number of platforms, and not just one platform, but a number of communication tools that we use to network and also learn from our colleagues globally. And I've written an article for the ESRA newsletter about this topic that gives much more detail than I can possibly provide in 10 minutes. Of the number of platforms, at least when you look at survey data from the United States, YouTube is definitely the most popular, followed by Facebook. And then there's a bunch of platforms that kind of make up this middle, which include Instagram, LinkedIn, Twitter, as well as messaging programs, like WhatsApp. I think one of the roles for instructors in regional anesthesia today is really to acknowledge the fact that all of our learners, including ourselves, those who are in practice already, who are out of training, we're going to the internet for most of our information, just like our patients also go to the internet for information. And so rather than recreating a lot of these high quality resources, I think our job as instructors or teachers in regional anesthesia is actually to help our learners know where to go. And so, one of the important topics that I address with our fellows and residents is which sites can you use to actually get good information. And so I just gave one link. This is not the only one. There are a number of very good channels on YouTube that you can use for regional anesthesia, but this one comes from the Duke University Regional Anesthesia Group. And they have very good high quality videos that go through the evidence as well as technique for various types of regional anesthesia procedures. And these can be very good for just-in-time training, especially for anesthetists in practice who perhaps don't do regional anesthesia on a regular basis. There are other sources as well, and I think that this is really important to look at because ultrasound has really dominated the field of regional anesthesia. It's very amenable to video-based platforms. So TikTok is another one, and Melody Herman, an anesthesiologist in practice who runs her own TikTok channel, does a great job posting videos that can be very educational and very short in terms of the amount of video content and learning points. I tend to prefer using Twitter, LinkedIn, and Instagram. So they're, again, not the most popular platforms, but I like them because of their format as well as the brevity in terms of the amount of information. And then, of course, while technically not a social media platform in terms of networking, it is the use of podcasts is actually a great learning modality. And some of our colleagues, Amit Pawa and Jeff Gadsden, have developed this Block It Like It's Hot podcast that I now listen to fairly religiously every time they have a new episode. One of the issues with social media, and I think that this is very important, is that it doesn't automatically have content curation. So there's no validation of the scientific basis for what is posted on social media. And so it's very important for us as teachers and as practicing clinicians and researchers in regional anesthesia to be very wary and as far as what is posted on social media, and then still continue to look at some of these questions as investigative issues that we still have to look into further. A good example of this was the aerosol box that was very, very popular at the very, very beginning of the COVID-19 pandemic. And you can see from the bar graph that there were thousands of tweets per day that were referencing this aerosol box. And then, of course, we had studies that were published subsequently using simulation design that showed that the aerosol box actually did not decrease the risk of aerosol contamination. And so much of that hype tended to die out. And not to say that's the same thing, but I think that we have seen the effect of social media hype in regional anesthesia, and erector spinae plain block is one example. And not to say that that it's all hype, because we also recognize that this is a useful technique that has particular indications. But initially, there was a lot of social media activity on erector spinae plain block, and this really preceded much of the now what we call well-regarded level 1 evidence using randomized clinical trials and meta-analyses of erector spinae plain block. And so the hype developed by social media definitely preceded the evidence for beneficial effect, and possibly led to a much larger indication or description of indications for ESP block. And now I think that our literature has finally caught up. And so I think that we have a much better understanding of when it probably is useful and when it probably is not useful. I think that what we really get from social media is a measure of public interest as well as attention. And so when you look at publications that are highly tweeted, using the Twitter platform as an example, we know that those are articles that very likely have some important topic or generate a lot of conversation. And that's probably important for us as practicing regional anesthesiologists and pain medicine clinicians to be aware of anyway. In addition, I think it's helpful for researchers if you know what's being talked about and what are controversial topics on social media. Those perhaps are important topics that you may want to pursue as far as research ideas for future studies. I think one of the important aspects of social media, in my opinion, is the ability to learn from conferences where you're not able to attend. And I think the reality, especially right now, with a global workforce shortage of anesthetists, is that we can't always go to every Congress. We can't always go to every scientific meeting. And so we're really going to have to rely on each other to teach each other what we're learning at conferences when we can attend. And so one of the important aspects of using social media, and in particular live tweeting from meetings, is that our colleagues are going to these meetings and they're sharing information that could be useful. Most of these tweets, when we've studied them, over 3/4 of these tweets are actually scientific in nature. So they can be high value, and they're coming directly from those conference halls that you're not attending, but they're getting information from the speakers that they can share with you. And I think as someone who uses social media to share information, I try to make my posts, my tweets matter. I want to make sure that they have good references and that they represent what the speaker's intent and message really was. And so if you have more information that you're interested in looking up as far as getting involved in social media, I'll reference this site. This is my own website that gives you a few pointers on how you can get started on social media. Thank you very much for having me.
Excellent points by Professor Mariano. We, unfortunately, as he hasn't been able to join us due to commitments, we will move on to our scanning session by Dr. Philippe Gautier, who is going to show us scanning of the spine.
Hello, my name is Philippe Gautier, and my topic today will be spinal ultrasound. This is a quite easy topic, because in fact you have only 3 things to know. You have a spinal process, you have an articular process, and you have a transverse process. 1, 2, 3 things to know. Quite easy. And each of these have its own characteristic. The spinal process is medial and extremely superficial, while the transverse process is the most deepest located and the most lateral. And in between, you have the articular process. Moreover, in fact, the spinal process, articular process, and oblique transverse process arrives successively. It means that you have a double oblique line, and this is quite clear when you do your transverse view. But before that, I will show you something whatever the level of competence you have, you must all know that it is extremely easy to find the midline. In fact, you have here the spinal process, you have a shadow, and here you have two muscular structure. In fact, you have a butterfly. And as soon as you have this image, you have the midline. And this is the most important thing, at least when you start. You can put your needle wherever you want and find immediately the same image. 1, 2, 3. So easy, isn't it? So once you have the spinal process, you move very slowly the image downside. And you see here that the shadow is going to enlarge. At the start, you have something that is very narrowed, and a few seconds later, you have something that is larger. And progressively, here, you have one first angle that is appearing. It is the articular process. So at this stage, you had first, a few seconds ago, a spinal process. Secondly, here you have already an articular process. Should you move slightly your probe downside, here you have a first angle, you have a second angle. So a few seconds ago, you have your spinal process, you have your articular process, and you have here your transverse process. When you are located at this level, in fact, you see that the spinal process is progressively disappearing while the two angles have appeared. You have here the articular process, you have the transverse process. You see that here the spinal process has disappeared. It means that you are in between, obviously, the two vertebra, and that your ultrasound beam is able to go downside, and it will hit here what Manoj Karmakar has called the anterior complex. And this anterior complex is, in fact, the vertebral body, the posterior longitudinal ligament, the epidural space, and the anterior dura. So it is a quite large structure. And facing this large structure here, the anterior complex, you will find the dura that is located most probably at this level. You will find it here. The dura is located at this level. You have the anterior complex here and the dura that is there. So that's one thing. Second thing, so I've shown you the midline, the transverse approach. I will show you something that is quite interesting, at least when you are a beginner. When we usually do an epidural anesthesia, in order to select the level with this movement, and this level is supposed to be the L3-4. But you have to remember that here we are caudally located. Here at the middle of the screen, you have the iliac spine, and that the Tuffier line, intercrystal line, is jumping from one crystal line to the other crystal line. So we should work not at this level, but at this level. And in between these two fingers, you see that you have exactly a 4 centimeters mistake. And a 4 centimeters mistake in at least pregnant women is often a 1 level mistake in the finding of the correct level. So, secondly, when you are looking on the sagittal, on the parasagittal view, you have still the 3 same landmarks. The most lateral one will be the transverse process. Slightly more medially and superficially, you will have the articular process. And once you have this articular process, then it is possible to go inside the spinal canal. You are moving from lateral, and you see that you have here optical shadow and optical window. You have a transverse process here, a transverse process here. You have an optical shadow here, and an optical window at this level. Sorry. We are at the level of the transverse process. And you see that the line here is completely discontinuous. Now I will move slightly medially. And you see very well that I'm jumping from one image to another image here. So we have the deep structure, we have a slightly more superficial structure. So we immediately note that you have here at this level the transverse process, and here the articular process. Yes? This articular process, because vertebrae are jumping from one to the other, forms a continuous line. At the level of the transverse process, you have a discontinuous line, while at the level of the transverse process, because the vertebrae are one above the others, you have a continuous line. Yes? So I said, 1, the transverse process, I move slightly laterally. I'm jumping from one structure to another structure. Yes, I have a continuous line, obviously. And now we are going to do a double oblique position of the probe. So I look slightly more medially and slightly more oblique. So, and we see that the view of the epidural space and of the spinal canal is much better. Yes, you have here the lamina, yes, you have optical shadow, optical window. So the beam, the ultrasound beam here, is able to go downside. At this level, you have the anterior complex, and at this level, I will show it again in a few seconds, you have the dura. Here, one structure, here, the other one. This is the dura, this is the anterior complex. So why do we select this view in order to have a much, we do it in order to have a much better view of the dura. In fact, when you do a transverse view, the ultrasound is reflected in all directions because you are on a circular structure. When you do a double oblique longitudinal parasagittal view, in fact, you can see the dura on a very linear, on a very longitudinal approach. And this is very clear on the screen in this case. You have once more the anterior complex, you have the dura here, you have the epidural space here, and here you have the yellow ligament with the spinal process, the lamina, sorry. Now I've shown you something very simple here, not to do mistake. As soon as you know, remember that this movement is not the correct one and that the finger must be located on the tip of the iliac bone, you have already avoided a great mistake. But you can do much more precise. You can put your probe on a very slightly paramedian view. You see that here you have the sacrum that is going downside. And when I go cranially, very suddenly you see that you have here a gap with here the anterior complex. Yes, you are really falling downside in the spinal canal. And once you have an anterior complex, you have just to jump from one to another level and to count. You have L5, S1, you have L4, 5, 4, 5, 3, 4 level. Once you have selected your level, you turn your probe here, and you know exactly where you are. And you have exactly your picture here, and what you are looking. Yes? Once more, we have normal spinal process. We have an enlarged figure here. We have one first angle here. We have a second at that level. The beam of the ultrasound goes downside. You have the anterior complex. And facing this anterior complex, we have here, just above my point, we have the dura. So, what I have shown you, first, wherever you put your probe, it's very easy to find the midline. Yes? Look, you remember? One, sorry. You have the spinal process here, the shadow here, and my butterfly. I have exactly my midline. Yes? That's one thing. Second thing, spinal process. Here I go slightly downside. First angle, spinal, articular process, and transverse process with a second angle. When I have these two angles, my ultrasound goes straight downside, hit the anterior complex, and facing this one here, you have the dura mater. Yes? That's quite simple. 1, 2, 3, all the times. For those who are doing some pain, it is possible to see the articular process, the facet joint. Yes, the facet joint is exactly located at this level. But as I said a few seconds ago, the dura is not always very obvious. It is located there on this view, and it is more easy to see on the parametric view. You have the transverse process that are located lateral with an optical window. We move medially. We see that we are jumping from one level to another level. This is the articular process. You see that this articular process form a continuous line, yes, and with the double oblique approach, you have, sorry, the lamina or the osseous sign, optical shadow, optical window, here the anterior complex facing a dura, an epidural space, a yellow ligament. Yes? Very easy. And if you want to be very safe when you are doing a spinal anesthesia on a daily basis, you just put your fingers on the tip of the iliac crest and not above the iliac crest, because you have, as you see, a 4 centimeters mistake. And if you want to be more precise, there are different ways of doing. You have here a very flat line up, and here you have the anterior complex. And you can count, once you have this picture, you can count and jump from one anterior complex to another one, here, yes? Or you can count the body structures that are just above. L5, 4, 3 at this level. So, I think that I have finished, and I thank you for your attention, and I hope that I have been clean. But spinal ultrasound is very simple. You have just to learn to count 2, 3. Spinal, articular, transverse process, and know exactly the geometry of these 3 structures. And you will always find your way back. Thank you for your attention.
Thank you very
T'es
much.
libre.
Thank you very much, Dr. Gautier. That was the last of our session. I would like to thank all our 3 guests that supported this trainee session, Professor MARIANO, Dr. LLOYD, and Dr. Gautier. Please follow our trainee group. We have specific webinars dedicated to trainees and novice specialists. And thank you for joining us today. Thank you.